Hello there, and welcome to this tutorial on the diagnosis and management of stroke.
Disclaimer, this video is aimed at medical students for learning and revision purposes only. For medical advice, seek a qualified clinician. Every effort has been made for the information to be as accurate as possible and in line with the UKMLA specification. However, if you find any errors, please notify in the comments. Note, this video is not sponsored or accredited by the UKMLA, MSc or GMC. Hope you find the tutorials useful. Best wishes.
Stroke is defined as a sudden onset, focal, persistent neurological deficit caused by neurovascular disease. Etiologically, it can be classified as arterial or venous. Venous strokes are rare, with cerebral venous sinus thrombosis being the most common type. Arterial strokes, which are much more common, can be categorized into ischemic or hemorrhagic. Ischemic strokes, the commonest type, can be caused by embolic disease or atherosclerosis, while types of hemorrhagic strokes include subarachnoid and intracerebral. Note that extradural and subdural hemorrhage are not types of strokes as they occur outside the brain parenchyma and are often from head trauma. However, they may exert enough pressure to reduce blood supply to the brain, causing a secondary stroke. Using the etiology, we can identify possible risk factors. Risk of atherosclerosis increases with age, being male, having high blood cholesterol, diabetes, or smoking, or being obese. Embolic disease is predominantly from atrial fibrillation. Blood stasis in the left atrium promotes clotting, which can travel and block the cerebral arteries. Other causes include endocarditis and coagulopathies. Hemorrhagic stroke most often is due to high cerebral blood pressure, which can be from essential hypertension, chronic kidney disease, and substance misuse such as cocaine and amphetamines, which can cause vasospasm of the arteries. Other risk factors include bleeding disorders, use of anticoagulants, and vascular malformation such as arteriovenous malformation. Note that patients tend to have multiple risk factors which can interact with one another, amplifying the risk of stroke. Example, a patient with diabetes and hypertension will have a higher risk than diabetes alone, and can develop both ischemic and hemorrhagic stroke. Now let's look at how a patient with a potential stroke may present with. This video will not cover stroke syndromes, and will be covered in another one. When outside a hospital, look for any facial drooping, arm weakness, or speech difficulty. If one or more are present, call for help. This screening tool is approximately 80% sensitive, i.e. for 100 people with a stroke you can detect 80 of them, hence why there is a national campaign with this poster. This is a patient with a likely stroke. Why? Because there is no drooping of the forehead, but drooping of the right side of the mouth. So where is the lesion? It is in the left cerebral cortex. Remember, unlike Bell's palsy, a stroke spares the forehead, which I'll explain why next. So why stroke and not Bell's palsy in the previous image? Well, each side of the forehead is supplied by upper motor neurons of both hemispheres. Because stroke is an upper motor neuron lesion, the ipsilateral hemisphere continues to supply the forehead and hence spare it from weakness. However, each side of the mouth is supplied only by a upper motor neuron of the contralateral hemisphere. Hence, a stroke lesion is contralateral to the weak side of the mouth. Now, Bell's palsy is due to a lower motor neuron lesion with ipsilateral supply only. So both the mouth and the forehead is not spared. The lesion in Bell's palsy is ipsilateral to the weak side of the forehead and the mouth. Click on the ribbon above to learn more about Bell's palsy. Now, when a patient presents to the emergency department with a suspected stroke, clinicians use a scoring scale called ROSIER, which stands for Recognition of Stroke in Emergency Room. It is used to rule out false strokes, i.e. stroke mimics such as hypoglycemia. The criteria can be remembered by the acronym FALS, which stands for weakness in face, arm or leg, speech disturbance, or eye problems. A score of 1 or more suggests a probable stroke. Note that syncope and seizure activity scores minus points, as this is not associated with stroke. After a thorough assessment, you're convinced a person has a stroke. Can you start treatment? Of course not. Why? Because you must exclude a hemorrhage, which can be done using a brain CT. Now let's look at the difference between an ischemic and a hemorrhagic stroke. Do you know which one is ischemic? It is this one. Note that most ischemic strokes are actually normal on CT, at least in the acute phase. The hypodensity in the left parietal region is due to cerebral edema, which may suggest that this person has been having symptoms for at least 12 hours. This means the CT on the right is of a hemorrhagic stroke. The hyperdensity in the right parieto-occipital region is due to clotting of blood. There is also midline shift suggesting a massive hemorrhage. This patient has been on warfarin, hence why it's always important to ask patients if they are taking blood thinning medication. Management of ischemic stroke depends on symptom onset. If it is less than 4.5 hours, thrombolysis with IV alteplase and a thrombectomy, i.e. clot removal, is indicated. If it is between 4.5 to 6 hours, then thrombectomy is done. Note that this can be offered up to 24 hours after symptom onset, provided that imaging such as diffusion-weighted MRI shows salvageable tissue. If symptoms occur more than 6 hours ago and there is no salvageable tissue, offer medical therapy with 300 mg aspirin for 2 weeks, followed by lifelong 75 mg clopidogrel monotherapy. Management of hemorrhagic stroke is simpler, at least for exams. You should urgently refer to the neurosurgical team, who commonly perform surgeries such as craniotomy to release skull pressure, and sometimes craniectomy. You've now treated a patient with acute stroke, so what next? We need to reduce the risk of recurrence. Controlling modifiable risk factors such as stopping smoking, maximizing control of diabetes or hypertension is very important. Following a stroke, all patients are started on high dose, i.e. 80 mg atorvastatin to lower LDLs. For non-embolic ischemic stroke, you give 300 mg aspirin for 2 weeks to reduce hemorrhagic transformation, followed by 75 mg clopidogrel monotherapy. If clopidogrel is not tolerated or contraindicated, then give 75 mg aspirin and dipyridamole. Dipyridamole monotherapy is third-line therapy if clopidogrel or aspirin is contraindicated. For embolic ischemic strokes, apixaban monotherapy or other suitable DOACs are indicated following aspirin. Thank you for watching. Hope you learned something from this video. If you did, please make sure to like and subscribe, and I'll see you in the next one.